So let me make sure you're recorded. All right, let's go for it. Here we go. So exam 2, we're on week 6. Congratulations for getting here, because I know that in itself is an accomplishment. I'm going to be doing the review for exam 2. So let's get going. So remember, your exams are on your day of your class. Come in a little bit earlier so that you can get set up and ready to go. There are some campuses that do provide a on-campus area for you. If you have that and want that, just let the professor, whoever it is, know first so that we can verify and give those codes, the access codes to these exams. So let's start out. Let's start out with osteosarcoma, part of this week's lecture. So osteosarcoma is a bone cancer. Usually, children will show up. They're adolescents, a lot of them, and a lot of them are adolescents males. So many of these children say, oh, you know, I just fell down, I hurt myself. They're limping a little bit. There's some pain, there's some swelling, tenderness, maybe some numbness in there. And finally it gets to the point where they start complaining. Bring them to the physician and we'll do a simple x-ray. The x-ray is done, finding that little fuzzy area on the femur bone. And now what do we need to do? Well, these children will go through a course of usually chemotherapy to shrink the cancer a little bit, but the whole bone must be taken out on this one. Any part of the bone will leave the cancer there. The goal, absolute perfect goal in a perfect world, is to be able to save the bottom half of the leg and put it up into the hip joint. That way, this child, instead of removing the whole leg, because it's the whole femur bone that goes into the hip, it will have something to attach in a prosthesis to, so to be able to be more active and be, quote, more normal with the prosthesis. That's osteosarcoma. Leukemia, another from this week's lecture. It is a cancer of the bone. Usually, we will give these children they'll come in with pain, bone pain, fever, just general being tired. They have low white counts. It is a cancer of the blood-forming cells of the bone marrow. And you will see that it is the white cells are just immature. So there's no infection fighting things in the blood. Now, we will put these children on chemotherapy. Once we've diagnosed, we have done a LP to look at if it's in the central nervous system, and we'll do a bone marrow aspirate to look at the cells that are in there. Then we will start chemotherapy. Chemotherapy for the first 4 to 6 weeks is what we call induction. It could be multiple types of chemotherapy, but with this induction, basically, we want to achieve remission. So what's left in the treatment is maybe a couple cells that weren't caught, and then, you know, putting them on something to prevent them from coming back, the blood cells. Antiemetics, 30 minutes before chemo, to prevent that nausea and vomiting is really important. So some children are going to need a bone marrow transplant. Whether they can't fight it with chemo, it's not working, we need to replace the blood forming area in that child. Now, there are 2 types of bone marrow that we can get. One is yourself, but usually we don't have that. So the best type of bone marrow that we can get is what we call allogenic. Means allo means other. Usually siblings are the best type of stem cells that we can get in order to help those children. What we do is take the child with leukemia, we give them radiation, and we completely remove all cells out of that child. Then we put in the stem cells from the allogenic blood cells from the sibling, and that replaces it. And then hopefully this child will be cured. So brain tumors. Brain tumors of the central nervous system are the most common type of tumors. It's 25%, 50% is leukemia, but the solid tumors are about 25%. The thing about brain tumors is that these children will have symptoms that start out slow. The tumor starts out small and then it grows, right? Taking more space up. So when it's small, you might have a vomit, you might have a headache, but as it progresses, gets bigger, so do the type of symptoms. The headaches and vomiting will get worse and worse and worse. And it's usually that it's not just with feeding, it's at all different times and there's no correlation. That's when the child goes in for treatment. The parent says, no, there's something wrong. So when we give chemotherapy, we know chemotherapy, the induction, our goal is remission, but we are putting intense chemotherapy into these children. And it not only destroys cancer cells, but it destroys all the good stuff in there, including neutrophils and white blood cells. What does that do? Well, that's your infection fighting system of your body. So as a nurse, we need to monitor lab values. One that's very important is the neutrophil count, because it can drop below 500, which means there's nothing in there now to fight infection. So if we are looking at lab values, see less than 500, this is a priority to make sure that we check this child, because the chance of infection, monitoring their vital signs, their temperature, and of course, hand washing is the most important. And when you look at this, days 5 to 7 is the nadir period where the neutrophil count is the lowest. So who is not on mute there? I got you. Okay, the nadir period is the lowest. So we know on day 5 to 7 that we really must be great with our hand washing and really protecting this child. Another cancer that goes on is something called lymphomas. We know that's in the blood, and then we know lymphoma is another place that's one of the most common types of cancers in children. Hodgkin's lymphoma, it's the most common thing that you're going to see is these big lymph nodes, but they don't hurt, okay? They don't hurt at all. So the parents see these big things and the kid looks okay, but it's so big they get scared. If it gets big, sometimes it might get swollen against the vocal cords or the airway. You might see some coughing, and if it progresses, of course, you see those symptoms of cancer, fever and lethargy and vomiting, and that might bring them in. But usually it's that big node there. And that cough is, again, because it's pressing in there, it's all that extra sort of space that it's covering. So with Hodgkin's lymphoma, they'll do a lymph node biopsy. And if we see Sternberg-Reading cells, we know it's definitely that lymphoma. So mostly you'll see that big node. HIV can happen in children. We know it can happen in any child due to rape and other things that, are where a male will abuse young children. But the other one most common that we're going to see is the HIV mother during having a baby. And we know labor and delivery and breast milk, all of those things we have to be careful with HIV mothers. Now, when we're talking HIV, one of our big things is the infant that's being born. And that infant, you have to be careful. Not all infants born with HIV become HIV positive because of the mother. Some can convert to not. I've seen twins, one with, one without. And the reason why that happened is because they really did everything to boost that infant's immune system. Now, candida can happen with children. Remember, the candida in the mouth causes all that extra stuff and pain and can really hinder with nutrition. So nystatin is a great choice to get rid of it. Respiratory wise, the big one happens between 3 to 6 months is pneumocystic cardiac pneumonia, PCP. So that one we really have to be careful for. That's why we're boosting that immune system of that infant at birth. GI again is a candida, and then we can have, integumentary about the Kaposi, sarcoma, candidus, but most common is your PCP pneumonia. So the focus again is on the infant's immune health. So if we're giving those antiretroviral drugs, it's going to slow the growth and give that child, that infant, a good chance. Again, nutrition is always important. If we don't have good nutrition, the body can't support the immune stuff that you're giving to them. And we'll treat them as we see what's going on. And again, if we can prevent some of these infections, candida and PCP pneumonia, that is really what we want to do in children. Sickle cell disease is inherited. It is where the red blood cells are produced, but produced in a sickle shape. What happens is in sickle cell disease is due to stress, due to dehydration, due to injury. These children can go into a vaso-occlusive crisis and go into a sickle cell crisis, and it is painful. It is a vessel, a bifurcation usually, where sickle cell just covers it and blood can't get down. So it stays up and swells that area, and it hits the nerves, it swells, it's painful. And then below, they're not getting oxygen. So again, that's painful too. So priority nursing action for a patient receiving a vaso-occlusive is to give IV fluids. And why? Don't you think it's the pain? Well, what is causing the pain? It's because the cells can't go down. So you dilate with IV fluids, now the vessels go down, the pain will decrease. And you're also going to give pain medicine. And then you might give some heat in the area because it dilates the vessel. Because it's the vessel being tiny, cells can't get through, which causes the pain. So IV fluids, number one, something for pain and heat, all are great. And then oxygen might be given because with these sickle cells, they're not carrying oxygen and the hemoglobin hematocrits are usually very low. So we'll put on oxygen. Maybe it's going to help give a little bit more to the cells. So there's all sorts of anemias that we've covered. Iron deficient anemia is the most common. It's not enough iron in the blood. And usually these children are complaining of being really tired. So how do we take care of it? Well, nutritionally, if we can get iron in them, that would be the best. But usually it is some sort of drug, whether iron dextran. And remember, this is an iron injection. It burns on the skin, and it also is a deep golden orange brown. It will stain the skin. So lock and load Z-Track and lock it in, deep IM, and that will help those children come back from it. Megaplastic anemia is when you're lacking your B12, and then there's a problem with absorption of nutrition. Hemolytic anemia has something to do with these cells are just being destroyed. Some of these are different sort of conditions that children have, or it could be infection or medications. Sickle cell, we've just covered, is just a sickle or abnormally shaped red blood cells. Cooley's anemia is what I call the rectangular type of anemia cell. And it literally has these cells exploding all of their insides out into the vascular. And what's inside a red blood cell? You have oxygen and you have iron. So all that iron is going in there and all that oxygen is going in there. So how do we take care of this? Well, These children will need blood transfusions for life. And then all of this iron going in there, they are going to need something to get rid of it, some iron chelating therapy, drug, or a apheresis will need to be done to take it out. So Cooley's anemia, the most severe of all the thalassemias, to live, you need blood transfusions. Aplastic anemia, it's the failure of the bone marrow to make all cells, white blood cells, red blood cells, and platelets. So this is an anemia, which is a failure of your bone marrow. So if you have an IV and you are delivering medications or just fluids, if you see it swollen, reddened, streaked, first thing, stop it. It's better to stop one of those IVs and restart it than have a child have some sort of necrosis of the skin. I've seen whole tops of hands and stuff removed. So you see it swollen, make sure, priority, stop the infusion, number one, and then take care of it. If you are giving blood at this time and you see something going on with the child, that you see shortness of breath, jugular vein distension, dry cough, you think breath, you think fluid in the lungs. Distension is too much fluid in the lungs, and then it's swelling, so you're coughing and coughing. This right now is probably too much, too quick, so circulatory overload. So that's what you would see with those symptoms. Immune idiopathic thrombocytopenia, I love that word, but when you think of it, think of ITP. P is platelets, okay? That means not enough platelets. It's also called thrombocytopenia, not enough platelets. Remember, P, platelets, not enough. So usually you don't see anything with these children with ITP, and then they get this upper respiratory infection. And a month or so later, they come in with this petechial looking rash. It's like purple, little tiny little dots, legs, trunk, back, arms, doesn't matter where it is, and bruising. And the parents are like, but this kid doesn't play, what's going on? They will do a CBC and you will see that the platelet count is less than 2,000, usually like 20,000 or lower at that point when you're seeing these rashes. So how do we treat it? IVIG, anti-D, and we're going to be giving some corticosteroids. Now, as a nurse, you have a child now that is diagnosed with ITP. It might be a transient disease, or it might be a chronic off and on for life. Hopefully, it's only an acute stage we can cure and it's gone. But as a nurse, you get these children admitted, you need to put them on bleeding precautions. You need to no IM infections, injections. You need to give these children, watch their hemoglobin hematocrits and follow them that way. They don't need IV fluids. This is not a sickle cell. This is just platelets. Blood is still flowing around. So we're gonna soft toothbrush, and we are going to just all bleeding precautions with that child. So anti-D, and we're also going to put them on the corticosteroids as they need. Now, there is a criteria to be able to put these children on anti-D, and it is only certain ages, 1 to 19. You have to have a good white count, and you can't be bleeding with no reactions. And you also have to have you have to have vitamin A. You can't be sick. You can't have any sort of immune disorder or no splenectomy. And this actually is part of the treatment. So anti-D, you're going to have IVIG, intravenous immunoglobulins, and then of course your corticosteroids as ordered. So when this child is, just admitted, have them rest. You don't want them bumping around, hitting themselves, creating more bleeding going on. Assess for bleeding, soft toothbrushes, no razor, no IM injections, monitor CBC, and corticosteroids as needed for this. Hopefully we can make it go away. Amblyopia is a lazy eye. The muscle in the brain doesn't know how to make them focus right. So you're going to see this lazy eye. So how do we treat it? Well, you need to make that eye work. And the only way is to cover the good eye and let that bad eye work for itself. And this forces this eye to work right. Usually that's all it needs for treatment. Strabismus is when you're looking and your eyes cross. So it's almost like cross-eyed, that you're going to see. And you'll see the eyes wiggling, trying to get in focus with this. This really hinders that depth perception because of the strabismus. And this is another condition with children. Early cognitive impairment. Now, we've gone through growth and development. We know gross motor is get up and go, anything moving. Fine motor is fingers, delays. So if we're seeing things like a child, their face doesn't look right, maybe lower ears, they seem to don't want to be touched. They don't like their environment, and you'll see an irritable child. You're going to see these children not able to grasp a rattle at 5 months. You're going to see them not being able to turn themselves over at 6 months. And when you see these delays, you need to put in some early intervention. Now, in the first year, you're going to see a child trying to express themselves verbally. And if we are seeing that they are not to the point at 1 year old or a little bit later, saying 1 or 2 words, mama, dada, something, the first thing you do when a child can't speak where you think they should be is when you need to put in for a hearing evaluation. Because if they can hear, then they should be able to speak. They can't speak, there probably is something going on with their hearing. Another thing with early cognitive impairments is they're not listening, they're not behaving the way they should. And of course, those normal milestones, none of them are being met. When you look at fine gross motor, they're not meeting them. So a child with cognitive sensory impairment is our little sweetheart of a Downs child. Probably why I got into nursing, why I got into pediatrics. I think they're the sweetest children on earth. They're short, stubby fingers, toes, and they've got the palate that's really high in their mouth. They've got a big tongue, and they've got these beautiful big almond eyes. Downs children are susceptible to cardiac conditions. Might be as simple as a VSD, and it might go, even farther to a truncus or AV canal, but you don't have to know those, but at least a VSD. They're very flexible. They can put their legs behind their neck. And there also is some difference with their neck, that they can move their neck in ways that most people can't. They've got a crease, and they've got this big wide space between their first and second toe. It's like their toe sticks out to the side like that. And the one thing about these children that we need to understand is that their nasal nose is so flat, underdeveloped, they can't blow their nose. They get mucus in there, and it causes respiratory infections because it sits there and it drips on their trachea. So children with Downs are, when they're hospitalized, they want to know who's around them. They're lovable children, and they know who they want to love, and they really are high anxiety. They need to be with their parents. Very important that we never separate them. And it really helps with these children listening and understanding, and they become even more lovable. So early intervention, when we're talking about infants, by 2 months, they should say a single word. By 3 to 4 months, they should be cooing, gurgling, and laughing. By 8 months, you should be able to say something and they imitate it back. By 10 months, they know when you say no. It's crazy how they understand. They pull their hand back. By age 1, they can say 3 to 5 different words and know the meaning. So again, if they're not doing this, you should be able to say, well, let's go get a hearing test. Something's going on. Autism. Autism's really not diagnosed to ages 2 to 3. These children will be those who they don't look you in the eyes. If you're calling them, they don't answer. They're in their own little world. They don't imitate like other children. You do certain things, they will do it back to you. They don't do that like other children. They also will take a toy and put it in a place, take another toy and put it with it, another toy and put it there, and then take this toy away and this one back and this one, and repetitive. They'll do that 100 times until you stop them. You will see really high verbal delays. They don't speak that much. And also their motor abilities aren't as good as other children. They don't want to be around people. They don't interact with other people. They hate lights. They hate sounds. So these are some of the things that you would suspect autism if you were wondering. Immunizations, we know we give a lot of immunizations to our infants. We give them at 2, 4, 6 months, 15, 18 months, and this helps a child against diseases, because these prevent the diseases or at least make them minimal. Now, if we are giving immunizations and a child is immunosuppressed or a child is on steroids of any type, they're immunosuppressed. We cannot give any live vaccines to them. It's just like adults, same thing, don't do it. So be aware of your child before we just administer vaccines. It's okay if families get them. There is no risk to them, because you'll have some families ask that, but the child, no. So as we are born, these infants, most infants will get their first hepatitis B vaccine before discharge. Most of them, some insurance, whatever verification say at first visit, but most of the time it is. Now, there are some families who do not believe in vaccinating their children. Many times it's religious reasons or personal beliefs, or they feel vaccines give autism, which is totally false, but they believe it. Or they saying, I just want more information before I decide to give my child anything. So those are things that you will see. So family-centered care, I mean, that's all pediatric is. It's not just taking care of a child, you are taking care of the family. If a child is admitted to a hospital, it is high stress. It is really hard for those children who are in frequent hospitalizations. In fact, they have the most stress. Have they had an experience that causes them to be scared? Maybe one nurse or somebody caused pain or didn't listen, or something happened that has affected the child. Then you have, especially younger children, separation anxiety. Mom and dad, the most important thing is to have those children have the parents stay with them. You will see a child become difficult, especially the male. And you also will see children, as I said, with cognitive impairment like Downs, be extremely stressed in the hospital. Skin care in a hospitalized child. Well, you think that children, if they're really ill, that they're not going to have the same things happen with the adult patient. You're wrong. A child can have foot drop and decubitus ulcers and get problems with their lungs and blood clots and everything, just like an adult. So how do we prevent these things in a child? Well, we're going to give them good nutrition. Nutrition, nutrition, nutrition. It helps their body, heal itself. Instead of just taking this kid and dragging it up and down the bed, because some of them are small, we can, but a draw sheet that will keep that shear from going away. Using lotion, a child who's not in a diaper, or maybe a child who is bleeding in an area, we're going to use a moisture reducing pad underneath and maybe a diaper too, just to keep them, we could keep changing it to keep them dry. These children should be turned every 2 hours as ordered by the physician. So make sure that, we're rubbing those areas like the coccyx and the hips and the elbows and the shoulders, and preventing those skin problems in hospitalized children. So you have a young child who's being admitted, and we need to do an assessment. So how are we going to do that? Well, first of all, if they're a young child, who is the safest person on earth? It's either mom or dad. Put them in their lap. And then, of course, don't just go right in and try to listen. First, make some sort of acquaintance with the child. Maybe it's, give them a little tickle, or give them a toy, or, if they're older, talk to them, tell them about how cute their hair is or their shirt, whatever. And then show them the equipment, let them play, and then you're going to do your assessment, and you're going to get an accurate assessment. So there are different sort of ways that we can have children express themselves when they don't know what they did wrong or was done wrong. They can just show you through actions. And this is some of the things here. So expressive play or expressive activities with play is the best opportunity for encouraging emotional expression, including a release of tension, okay? You also will see anger when they are throwing things, when you see the tricycles, the wagon. So this can show you if they're upset or if they're happy. Another thing is dramatic play. And this is a very well organized technique. And this can have the child reenact what happened. So now you are seeing that how they're confused. Maybe you have stuff about, medicine there, like this little picture, and he's telling you that shot hurt. Maybe he's holding it and telling you that. And that's through dramatic play. And it's really important in some children. They can express themselves when they don't know how to verbalize it. And creative play is drawing or painting. And you can see how they're expressing their feelings. Are they happy? Are they sad? You can find out. So any child who is in pain is not going to be a happy child. So if we are going to have a child in pain, number one, we need to do our scales. So this child is older than 8. So in numeric scale, how much pain are you having from 0 to 10? So making sure we know when was the last dose, what did they get? Also, if we can, it's not just those pain medicines, okay? So we can reposition them. Now, maybe this child's had cardiac surgery, abdominal surgery, you've repositioned them, they've had something for pain. Now these children are moving for you. Now we can tell them how to take deep breaths and cough. If you're in pain, are you going to do an incentive spirometry as well as you can, or get out of bed, sit in a chair, or splint your incision and cough? No. So in order to help a child, get better quicker and prevent these complications, we're first going to give something for pain, and then we can do all the other stuff and keep those lungs moving and prevent blood clots to the legs, etc. Now, infants, for the first 6 months of life, for a fever or pain, can only get Tylenol, acetaminophen. But after 6 months, you can give either the pedioprofen, ibuprofen, and Tylenol, and alternate them. Aspirin is only given with Kawasaki disease, okay? Besides that, we never give it because of the possibility of Ray's syndrome. Again, IV site, you see something's going on, swelling, redness, pain. First thing, stop the infusion, elevate it, let the physician know, and then if we have to restart the IV,
If this bothers you guys, let me know. I'll go to another room. I have a Zoom on.
Okay, gastrostomy tube care. So many times we need to feed a child, and I've given you a couple different types of gastrostomy tubes here. See the one with the little thing attached? It's a button. It's great because the tube comes off when you're done feeding. The other one looks like a Foley catheter coming out. You can't remove it. So make sure you secure it well. Now, when we're doing care on these children, we need to clean it with soap and water. That's it, at least once a day. Don't turn it, no peroxide. And we just want to keep it secure to the abdomen, and that's all we need to do for it. Oxygen is another thing that we do give children quite regularly, and you can see a couple different ways here. Now, the best way, the children love it, is actually this oxy hood. If you can see, the child can look around, nothing's bothering them. They can put their hand up, they can have a pacifier in. The nasal cannula tends to tickle them a lot, and it's taped on their face, and they tend to pick at it. A ventilator, it's uncomfortable. If you've ever been ventilated, you'll understand. And this other one is CPAP, or continuous positive pressure flow, and it's blowing air and it's all of this stuff on their head. So the most tolerated is an oxy hood. Now, oxygen can be delivered. Sometimes the only choice is a little nasal cannula. You can give up to 60%, but you'll never go to 10 liters on a little infant like this. You might go to 2 or 3 liters, and then you'll have to choose something else. So we sometimes need to get a catheterized urine from an infant. Why do we catheterize an infant? Well, it is the most accurate urine specimen if we catheterize it. So we can bag the child, but what are we catching? It's going against the skin, and especially on a female or even an uncircumcised male, there's a lot of extra debris there that could alter the results. So we take the catheterization. Usually it's a little kit, put a little lidocaine jelly on the meatus before we start, don our gloves, get ready, and we will have the parents at the head of the bed, usually just holding the arms and just cooing with the baby. Another nurse will be holding the legs so that the child doesn't kick, and we'll get it in and come out real quick. Males do not like to watch their son catheterized. They think it hurts. Well, it's uncomfortable, but the lidocaine jelly does help. And in girls, they think that their virginity is gone, but it's a different hole. And sometimes we need to express that without them asking, because you could see it on their face. Intake and output, what do we count? Well, intake is anything that goes in the mouth or the IV. Now, if we are looking at a child with strict INOs, sometimes we need to flush IVs and give medications. That amount also needs to be counted. What is output? Urine, stool, vomit, drainage from a fistula or NG tube. You can guesstimate the sweat and then any drainage that comes out. So either way, the diapers, the chucks, the linens are all things. So what did you put on? What did it weigh when you took it off? What did it weigh? The difference is gram per ml is a 1 ml of urine. 1 gram of weight, 1 ml of urine. So when we are giving medications to a children, if you're a baby, just hold them just like you would if you were going to feed them. You put the syringe in the mouth and you squirt a little bit between the tongue and the side of the mouth, very, very slowly. And you will sometimes, they don't swallow. Now, if you are allowing the parent, and you should have the parent be giving it. Now, if the child's not swallowing, if the parent, not you as a nurse, but a parent blows a puff in the mouth, they tend to get scared and they gag and they swallow it. And it's a great way for these children to take medications with just a blow, a puff in the mouth, and it helps them to swallow medicine. Chronic otitis media is an infection of the middle ear, and it is a bacterial infection. And you could see some bulging eardrums here, and then you see one where you see a lot of debris coming out. Remember, this hurts, okay? It is an infection that needs oral antibiotics, and the concern is frequent ear infections that can cause the hearing to be decreased. But sometimes if you're having these chronic infections, they'll put tubes in, and that tubes just keeps that stuff draining so it doesn't back up in there. So pain medication, Tylenol, Motrin, depending on what you can give, and oral antibiotics, and complete it. Upper respiratory infections are mostly viral infections. What you see in bronchitis is a non-productive dry hacking cough worse at night. And usually you don't see a fever with this one. It's just you go to bed at night, you lay down and you cough and you cough and you cough. How do you treat this? Well, it's a virus. So you're going to take a cough medicine to suppress the cough so that you can rest and sit up a little bit in bed. Maybe children that are older, maybe a pillow. Asthma. Asthma is when the airways get inflamed and narrowed and swell and they rub, and it just causes a cough, 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 cough. It causes the point where you start wheezing. It starts with a prolonged expiratory phase. You get the air in, but it's hard to come out. So how do we treat it? Well, we give rescue inhalers. Your Proventil, you give your albuterol. Now, you get a child coming in and you see that the parent says, well, they've had 4 puffs, but the child's not getting better. Well, you ask, did you use a spacer? Depending on the age, maybe they didn't get the medicine, because you hear 4 puffs, that's a lot. So you need to investigate more. Think, well, let's be the detective here. Did you use a spacer and did it work? Does the child know how to do it? And that will help. Also with asthma, we are going to be giving steroids, decreases inflammation. So asthma is chronic non-productive cough, diffuse expiratory wheezing, and usually there's just no fever. It's they got with an antigen, which irritated the respiratory system, cough, cough, cough with the swelling, then the expiratory wheezing, but it's not a fever. So cystic fibrosis, another respiratory condition, is also passed on to the child from the parents. Sometimes we don't know that a child might be cystic fibrosis. So how would we figure that out? Well, at birth, there's a meconium ileus, which means they're not moving, passing that meconium. And it's usually within the first 24, 36 hours. You don't see that meconium pass, they're going to be doing an examination to check for cystic fibrosis. What do? We do a sweat chloride test, sweat test. And that sweat test will tell us, does the child have cystic fibrosis or not? So cystic fibrosis passed on to parent. You're at an infant, if we're not understanding the child could have CF, that we're going to see no stool of that meconium, and then we're going to do the chloride test to show that they do have it. With cystic fibrosis, it attacks the lungs and it attacks the small intestines. And another thing that we see with these children is these large, bulky, horrible, horrible smelling stools. Because you are not absorbing your fat-soluble vitamins, you're going to be deficient in your ADEK. Because you're not getting nutrition, you're going to have weight loss. You're going to hear, again, the lungs are like petri dishes, clogged with all sorts of mucus. You'll see dyspnea, wheezing and retracting, and this dry cough, dry cough, dry cough. And these children will chronically be in the hospital with respiratory infections. How do we treat cystic fibrosis? Well, we're going to be giving pancreatic enzymes to help with absorbing the nutrition we need from the food, and mostly important, respiratory is always the most important, aggressive chest physical therapy. These two vests that you see on these children, they vibrate this kid like this really hard. And you could see this one girl's doing her aerosol at the same time. So we want to get that stuff into the lungs to help the lungs open. Now, because it's sweat chloride test, it means sweat has salt that comes out, and that's what we see. So these children need salt. They need more salt than normal. They also need their vitamin supplements, like I said, and we need to make sure that we keep those lungs as mucus moving as much as possible. So just saline and bronchodilators. Again, chest physical therapy. You have a picture of using just a cup on them. And here's a picture where you put the head down a little bit lower, and you also pat with postural drainage. Very, very important, most important thing on these children, that they get up, they move, they exercise, deep breathe, cough, and get their chest physical therapy. So this enzyme, the pancreatic enzymes, we know cystic fibrosis is lifelong. There's nothing we can do to cure it. The only cure is a double lung transplant. Now, the thing with males usually are infertile with cystic fibrosis. What's pretty cool is once they get their double lung transplant, they're able to have children about a year or so out after transplant. And I think that's a really neat bit of information. So pancreatic enzymes are given 30 minutes right before meals. Right before meals, you're going to take it because you're not going to digest food. So if they're an enteric coated anything, we're not going to crush or chew those. They must be taken whole. If you have those capsules like the picture and you're young and you cannot swallow them, just sprinkle it on the food. But make sure if it's a powder, you're going to rinse your mouth. It helps because it will irritate the mucus in the mucosal lining of your teeth and mouth. And the one thing we forget with children is they grow, they get more pounds on them. We need to adjust it as these children get bigger. The long term, as I said, is that best lung, double lung transplant. These children do become adults. And as I said, usually 1 year post lung transplant, they have a chance to have offspring. And I think that's pretty cool that they have that ability, if they do get that. Post-tonsillectomy care. Well, this is the tonsils are removed in the back of the throat, and they send these children home now right after doing it. You're given instructions, and what you should instruct your parents and your children is no highly seasoned, irritating foods. Limit the activity because there's actually a clot on either side that's formed, and it's cauterized with those tonsils. So it can dislodge and they can bleed a lot. Plenty of fluids with anything you want fluids. A nice ice collar on the neck is really good. Popsicles, but don't give them red ones because you don't want to think that they're bleeding. So any other color. You should really watch these children. If you see them swallowing, and that's telling you the back of the throat, that clot has disappeared and it's leaking, it's bleeding, and they're swallowing. And older children, because they get pain and it goes up into their ears too, they have to chew gum, and it does work. They sit and they chew, and it does help with the pain and also with the ears too. So that's how you take care of tonsillectomy. Another thing that happens with colds is that some of these children, they're breathing so their mouths open, they can't breathe, they're so full of mucus that the physician says, let's put them on some nose drops to help them. The problem is if the parents use them more than 3 days, this child's going to be worse afterwards when they have less mucus because it causes the swelling. It's called rebound congestion. So adults, children, doesn't matter. Rebound congestion can occur. So warn your parents. Now, epiglottitis is like a croup, but they don't treat it. And croup is that barking cough. So then the epiglottis, which usually just covers the trachea when you swallow, swells. So it's covering the trachea, which means there's no airway open. So if we are looking at a child suspected epiglottitis, you are going to see this child drooling. You're going to hear a very little bit of air going in. If they're able to talk because the back of the throat is so full. Now, as a nurse, you want to go and look inside. No, whenever you see bent over, drooling, muffled voice, never, ever go in there and look at the back of that throat. What you can do is increase the swelling, and now you could shut off that little piece of air that they're breathing through. We treat it, racemic epi, we give that steroids, and it usually helps. I've never seen one get to the point of trach. As I said, croup is laryngotracheal bronchitis or swelling. If it goes untreated, as I said, can go on to epiglottitis. It is, again, a virus. The biggest thing, the biggest assessment you'll hear is from across the room. It's barking, and it sounds just like a seal. Sometimes you have a very low-grade fever, and you might hear some inspiratory stridor on these children, but most of these children, you will just give either a dose of steroids or they'll put them on a couple of days of steroids morning and night in order to decrease the swelling in their throat. RSV, respiratory Cynical virus, is a cold for you and me. But if you are a little infant, less than 3 months old or 6 months old, that area, your life is sucking, swallowing, and breathing, and it's hard to do all those things. Now put mucus in the nose and in the throat. Now you can't breathe. Now you're a heart condition, you're premature, you have lung problems. These children need protection from this because they cannot tolerate it. So we'll be given preventative monthly immunizations called Synergist, and that is the trade name, and Pavizmabab is the generic name, and it is given for the months between fall and early spring, which is the high risk times for it, and that can help prevent them getting RSV because they're having a hard enough time, as I said, sucking, swallowing, and breathing. Mononucleosis is also called the kissing disease. It is usually, there is a sore throat that is continued. What happens is it's not strep, it's not the flu, it's nothing, it's a virus, but it's what we call an Epstein-Barr virus. And this Epstein-Barr virus, it can be spread through sharing glasses of water, kissing, et cetera, et cetera. You will see a child who has a sore throat, it's not getting better. You will see the child start an antibiotic, still not getting better. Seek care again because they're fatigued, they have fever, they have rash, aches and pains, their glands are swollen, even their spleen or liver might be swollen, with this sore throat. These children, they'll do a monospot test. They'll find out it's positive, and they'll be given a code of what to do for discharge. Well, they need to rest. They need to take fluids, Tylenol and Motrin for pain, for the pain or for fever, or just when they just don't feel well. The biggest thing we need to tell them is no PE, no sports. You need to protect that abdomen because the spleen can rupture and these children can die. So it usually takes several weeks for these symptoms to disappear. So they cannot PE or any sports until they're cleared by their pediatrician, usually 3 to 4 weeks later. Cardiac, tetralogy of Fallot. Think of cardiac, think of the right side of the heart. So you will see a pulmonic stenosis, a narrowing. You'll see the VSD, which is just an opening between the right and left side of the heart. And you will see the aorta gets pushed over and a right ventricular hypertrophy. The right ventricle is hypertrophic or stretched out because when that stenosis, all the blood can't get there, it stretches that right ventricle. That's why. Now, these children will scare you. My little Nathan had a TET spell on me one night about 3 o'clock in the morning. I worked nights. And he went from O2 sats of 100 to 10 in, it must have been 15-second splat. What happened is something went, like I call it a flap of skin or tissue, went over that pulmonary artery. So blood was not going into the lungs at all. So what is the treatment for a TET spell, a blue spell? This picture on the bottom, knee to chest, whether it's on the side or up like that, depending on their position. And what it does, it changes the pressure between the abdomen and the chest cavities, and it pops that piece of tissue off. And then blood flows and they're fine. They do surgery on these children and they're corrected. Now, see that boy up top? You can have older children with tetralogy that have not been fixed, and they themselves can go into a TET spell. And what they do, they just know what to do. They squat just like that boy, and it does the same thing as we've done to the infant. It's a knee chest position, and it pops it off, and they're able to oxygenate. So there are types of congenital heart disease. Acyanotic, which means their O2 saturations are normal. Cyanotic means their O2 saturations are not normal. They can be normal at 65%. That's cyanotic. I want you to know what pulmonary blood flow is when it's increased. Now, the left side of the heart has 4 pulmonary veins that dump into the left atrium. So that's a lot of flow, a lot of pressure there. And of course, the left ventricle has that left ventricle, the big pump. So the left side has a lot of pressure. Now the right side of the heart has the blood just coming back, okay? After the left ventricle pumps it to the body, so it just gets up into the right side. So pressures are low. So if there's a hole, either the upper or lower chambers of the heart, it's going to go from high to low pressure. It's just what pressure does. So we know left atrium is higher than the right atrium. So it's going to push blood. And what's going to do is going to recirculate or increase the pulmonary blood flow. Whether it's the ventricle or the atrium, blood is pushed from the left side into the right side and back up through the right ventricle and the pulmonary artery, back to the lungs, comes back, and let's do it again, and let's do it again. And that's what those 2 septal defects, why it's increased pulmonary blood flow. Remember that the patent ductus arteriosus connects pulmonary artery to the aorta. So again, I'm connected to the pulmonary artery. It's going to have some increased flow there. Coarctation is a kink. Remember, blood flow goes back and it fills the lungs up. because it can't go down. Tetralogy is the most common of decreased blood flow. And remember tricuspid atresia, A, absent, there's no blood flow going from the right atrium to right ventricle, which means there's no blood flow going to the lungs. That's why that's cyanotic. And then the last one you need to understand is transposition of great arteries. It means the aorta and the pulmonary artery are switched. And in order to live, you need to keep that patent ductus arterius open, and you keep it open with the body's natural thing that keeps it open during fetal circulation, prostaglandins. It's a synthetic form, but it works the same. And what that does, it increases oxygen because now there's a connection, and now the heart can flow the blood around, so it increases cardiac output. So you have children that are infants that are born, and there are, all of a sudden you start to see symptoms which are making you suspect that they might have a congenital heart defect. When you start seeing an infant having a heart rate above 160, okay, they're tachycardic, there's something's going on, the heart's trying to work real hard to fix it, but it's beating fast. And of course, if that's not working, you're going to start breathing faster too to try. And because blood doesn't circulate well, you might see swelling somewhere, you might see some cyanosis. One of the big things is you're going to see is these children are going to tire easy because there's no oxygen. These children will have very fatigued. They'll eat a little bit and they'll fall asleep. They're tired. There's no oxygen in there. And that will cause a child to have failure to thrive. And then there are differences in pulses, especially with coarctation. There's nothing on the feet, but you're going to have big pulses up on the arms, and on the jugular, you're going to feel a lot of pressure up there. So transposition is that switched. The arteries for the aorta and the pulmonary artery, they're switched. So we know that without a connection, there is no connection to the oxygen. So this child needs that prostaglandins to keep it open, and it can keep it open as long as we continue that drip. And this helps with oxygenation, and it helps with cardiac output. And because we are making sure oxygen is going to the brain, it's going to prevent any problems, with hypoxia type symptoms, the central nervous system stuff with these children. Another thing is tricuspid atresia. Now, I just explained it. Let's do it again. Atresia, absent valve. You see the right atrium, right ventricle. If you look at the picture, it's just a complete door. Nothing's opening. So this is a decreased pulmonary blood flow. So atresia is nothing, absent. And stenosis is a narrowing. That means you still get something going there. Many children who are cardiacs get chest tubes. And chest tubes usually are removed a couple days after surgery when they stop draining. If a child is old enough, these children can be very scared to get them removed. Plus, even moving, they feel the pain of them. So make sure we explain to this child, what are you going to do? And be honest with them. You will give them a pre-medication. Tell them you're taking care of the pain the best you can. They might feel a little, but it's not going to be for a long time. It's just initially, it's a burning hurt. It hurts. So that's what it feels like. You also, because you want to monitor, the pulling of the tubes and the pain medicine, take vital signs before and after. And always tell that kid he did a great job, because it is scary. Have the kids sitting up because you want the diaphragm down so they can breathe easier, okay? Medicate them, let them know what's going on, and monitor vital signs. In a transplant, the most risk is organ rejection in the first 6 months of life. That's the biggest cause of death in transplant in children. If they do survive beyond that 6 months, they're always going to be on anti-rejection drugs forever. Infections are a risk, but the biggest one is the rejection of the organ. We talked about that patent ductus arteriosus. Let's talk about it a little bit more. It connects the aorta to the lungs, and it gives the body oxygen when it needs it. So one of the things with a PDA, patent ductus arteriosus, is you sometimes need to close these. Some children, especially you're premature, and they have this open, and it wasn't because we kept it open, and then we need to close it. You will see a child who has something called a wide pulse pressure. Now, premature infants, they might have a blood pressure of 60/15. When you close the PDA with indomethacin, which is the medicine we close it with medically, you will see that blood pressure go to 60/40 from 60/15. That's one thing that you can see. Also, the murmur, that big murmur that you hear between them will disappear. I used to like listening to them as I gave indomethacin to see when that ductus closed. So to keep a PDA open, prostaglandins, it oxygenates and it increases cardiac output. It decreases central nervous system problems. When you want to close it, you give indomethacin and you will hear a murmur go away and the blood pressure, the numbers will be closer together. So things to do with a transposition, we know it's the switch. We know the PDA keeps it open. We know prostaglandin is there for that good oxygen level, maintain cardiac output. And the name of the surgery we do is called an arterial switch. Rheumatic fever is caused by strep throat that wasn't treated or not treated completely. These children usually come in a couple weeks later, and usually it's the joint pain and the rash that bring them in and the fever. These children have that big erythema marginosum rash, not the tiny little rash. It's the big, I call it demarcated looking rash. And another thing that with all of this, they have chorea. Their gait, they're shuffling, they're falling, something's going on. So fever, joint pain, rash on the trunk, you're going to see these nodules. And if it's left long enough, they're going to have damage to the heart. So how do we treat rheumatic fever? Well, it's a strep infection. So we're going to have a long course of antibiotics, usually 4 to 6 ways, 4 to 6 weeks. And if we take care of that soon enough, and we didn't let it last too long, there's going to be no heart valve. So everything will go away. Chorea will go away, the rash, the nodules, joint pain, everything. So it behooves parents, if they see these things, get these kids in quickly so we can give that long course antibiotics. Now in cardiac, infants, children get the same medications as adults. There's no change. So digoxin increases contractility. It slows down the heart, makes it more contracting, so it works more efficiently. So this is a common drug given, especially to your congenital heart defect children. These are infants. So how are you going to see if an infant has dig toxicity? Well, in adults, we're going to hold the digoxin for a heart rate less than 60. Well, a newborn child could be 140 to 160 normal. So usually they say 90 to 100 heart rate. If it's that low, hold it. But if you see an infant vomiting that's a big telltale sign. It's big red alert to hold the digoxin and then to do a dig level. Sometimes you'll see the heart rate slowing down and you might see some dysrhythmia, some PVCs coming in. That means the heart's too slow. So you see vomiting in an infant. And if you see the heart rate down too, definitely hold it, do a dig level, and find out before you give it. So you have a kid, you suspect a congenital heart defect, you've done an ultrasound, something looks there, you're going to go to cardiac cath in order to find out exactly what's happening in the heart. And what they do is they insert two big catheters into the femoral artery and femoral vein. When the procedure is done, they will take out these big catheters and apply pressure, and they will put a pressure bandage on it and a sandbag on the older children. But many of these are newborn infants. So just a big pressure bandage. Now, first thing you are going to do when this child comes back to your care from cardiac cath is check for bleeding. These vessels are huge, and if a clot pops off one of them, the femoral artery, an infant can bleed out in a minute. It's very quick. If you see that this child is bleeding from one of these sites, you put pressure with 2 fingers above the insertion site, closer to the heart, and hold it and call for help, because that's the only treatment, is to hold it, which again is putting a, like a finger on a bleeding area. It will clot. So after that, you're going to check the extremities, check the pulses, you're going to check vital signs. You can give either IV or PO, doesn't matter, fluids. And some of these infants were given a IV with sugar in it, so monitor your dextrose sticks, your blood glucoses. Also, children do get high and low blood sugars just from stress. So post-cath priority, check that dressing. If it's bleeding, put your fingers above it and press, call for help. So children, when they are put in the hospital, especially the young ones, they'll regress. They're not happy, they're not in their own home, they're scared, and they will show things that will show you that they need mom and dad to stay with them. So young children who are potty trained, all of a sudden they're not using the potty, they want a diaper, or they're incontinent. Some children who sleep from 8 o'clock at night till 8 in the morning, they're not going to be sleeping. They are going to want more attention. A lot of times you will see children, usually you'll have, the 3-4-year-old likes to go to the toys and play. Well, in the hospital, no, they want mom and dad to play with them. And then this child, this toddler, this preschooler is going through a lot of anxiety when they're unable to play with themselves. Children can self-soothe themselves. We know the infants, it's all oral, everything suck, swallow, bite in the mouth, and that really is. We know some children can go into crying and temper tantrums and behaviors that's just not normal for them. And some of them get to the point where they withdraw and they don't want to talk at all. As in anything with doing any procedure, always allow the child to play with the instruments before we do it. And the biggest stressor is when the parents have to leave. So know that you might see that incontinence, you might see those temper tantrums, you might see that need for you to be in the room with them. A school-age child does like to have the same routine as home. So And it's important for, especially even younger children, to keep the same routine. When do they wake up? What do they eat for breakfast? When do they take a nap? When do they take their bath? Try to maintain the same routine. And this is going to help them have comfort. They know what's coming next. And that is a stress reliever. So you need to take blood from an infant. We can do heel sticks. We can get a CBC and a whole big chem profile for 1.2 mLs of blood. And we could do that through a heel stick. Now, how do we get all of this blood and do it without squeezing and hurting and bruising this heel? Well, you're going to stick them only in the middle of the heel. You're not going to put it in the middle. You're going to put them on the sides because it'll come out. Plus, you can hold it on the side to put it in these little tiny little tubes. But if you have that leg with an approved heel warmer, so this is like those little red and white bags, and you pop, and it's a heel warmer that has been approved for infants. You can put it on that heel and warm up and dilate those vessels. Never, ever do hot water or something from a microwave because it's all you have. No, because these children have very fragile skin. You can burn them. And you will see if you do it on the side and you have an approved hospital warmer and slowly squeeze it, you can fill up a lot of tubes of blood. So parents are complete part of the care of your child. Trying to let parents do as much care for the child is important because they need to take the child home, especially those children who are going to need more complex things, G-tube feedings, medications. Let them start to get responsible for it. But remember, in the end, the nurse is the one who's responsible. The nurse is the one who needs to make sure that the child's doing well and continually assess the child. Again, leaving that parent in the room, getting them comfortable with their pillow and blankets for their bed or in the child's bed, it's okay. It does relieve their anxiety, not only for the child, but for the parent too. So you're going to have 5 simple dosage calculations, very much like the last ones. Know that you study this. You can go over the Kahoots that I've sent also, which is on my YouTube, Professor Bogart, Pediatric Nursing. You know, you have a lot of tools to use. So study this. Know that it will be posted as soon as I can. Does anybody have any questions?
No, thank you so much.
Review. Thank you.
Have a great night. Oh, you're very welcome.
You too. Thank you.
You too. Thank
night.
you.
My
Thank you.
pleasure.
Thank you.